The neurological exam consists of 5 sections: gait and attitude, cranial nerve examination, placing and proprioception, spinal or appendicular reflexes, pain evaluation, and palpation. Each will be visited in this video. Let's take a look at gait and attitude. Magnum, 1.5-year-old cattle dog, is attentive, alert, responsive. He's able to gait properly, has no ataxia, no dysmetria, no weakness or paresis, and is not paralyzed. Some examples of abnormal gait and attitude. This patient shows evidence of ataxia, being hunched up, and is definitely neurological. This patient has wobbler-like gait with short and choppy front gait with pelvic ataxia or wobbliness. This patient, a cat, has paraparesis with a tail that is flaccid. This cat shows evidence of obtundation and not being as responsive as a normal cat should be. The tools you need to complete the neurological exam include the following: a stethoscope, forceps, a pleximeter or reflex hammer, cotton balls, Q-tip, treats, and a pen light. When it comes to pen lights, they are not all the same. One must consider the options. This pen light is a pen light you can buy for almost any distributor. It is easy, affordable, but does not shine very bright. This pen light is your cheap Ace Hardware or local hardware store purchase, very bright LED. This pen light is the one that I prefer. It is very bright, it is solid, and will last a very long time. The alternative, of course, is a trans illuminator. Cranial nerves. The first thing before proceeding with cranial nerves is to take a look at the symmetry of the patient. Take a look at the nostrils. They must function symmetrically. Right and left must be equal. Ear position. Eyes. Globes must be in the same position. Pupils must be as open left and right. Muscle structure must be just as good on the left as the right. Olfactory nerve, cranial nerve 1. This is a difficult test to do, and it does not assess left from right. A treat is the easiest way to go about it. Place the treat in one hand. Allow the patient to settle in and settle down. The trick is to present both hands to the patient without the patient knowing where the treat went. In this case, this dog is easily distracted and does not really know which hand the treat is in. It can be important to let the patient smell the treat first so it knows what it is looking for. Cranial nerve 2, optic nerve, tracking response. This is a response. Vision is the afferent, and the response is either the eyes looking towards the object or the entire head turning towards the object. This response involves the colliculi in the midbrain and of course the motor cortex, with connection to either cranial nerve 3, 4, and 6 for eye movement, or the motor cortex to movement of the head and neck. A cotton ball is used as it does not make noise, nor does it have any scent. It is best to drop it from a place where the dog cannot see it coming. Optic nerve, cranial nerve 2, menace response. This is a learned response. It involves vision, cranial nerve 2, ends up being coordinated in the cerebellum, and the response is a blink of the eye or cranial nerve 7. You can use a pleximeter, you can use your finger, you can use your hand. Cranial nerve 2, optic nerve, also responsible for pupillary light reflex. We will shine a light in one eye and look for the pupils to constrict. It is best to start in a dark room or close the eyelids first. As one pupil constricts, the other one should also do so. This is the consensual response. Both eyes are tested equally. Both eyes should respond with direct stimulation and consensual. Let's take a look at this dog with a brightly lit room, still using a pen light. Close the eyelids, and as you open them, shine the light brightly. Some patients will not appreciate the brightness. Cranial nerve 2, optic nerve, visual placing. This test is best for cats or smaller dogs. Find a chair or table surface. Hold the cat in a position that is uncomfortable for the animal, and as you approach the table or the chair, the patient should place in anticipation of the surface. Switch hands, switch leg. This can only be done on the thoracic limb. 4 and 6, oculomotor, trochlear, and abducens are responsible for the physiological nystagmus or ability of the patient to move its eyes in any direction. Hold the head steadily and move the patient's head side to side. In the case of a cat or smaller dog, you can move the entire patient side to side facing you. Look at the sclera and look at the globe. There should be a slow phase delay to the opposite side of the motion and a rapid catch-up to the side of the motion. This is normal physiological nystagmus. It can be done up and down as well. Cranial nerve 5 and 7, trigeminal and facial, are looked at together. Must pay attention to the symmetry of the face. 7 is in charge of facial expression, 5 is in charge of sensation to the face, and as well motor to the muscles of mastication. The eyes should not be protruding more or less. The nostrils should be symmetric, the lips should be symmetric, the fissures of the eyes symmetric. Tap the medial canthus, look for a blink. Sensory is 5, motor is 7. Afferent is 5, efferent is 7. Some dogs will be slower on the lateral canthus. When they get older, if we look at a younger animal, as we will see in Magnum, the reflex can be much faster. What we call brisk. Cranial nerve 5 and 7, trigeminal and facial, we are looking at vibrissae. Sensory 5, tap the vibrissae, look for a blink. Efferent is 7, facial nerve. Pinching the lip can also lead to a wrinkle of the lip or pull up of the lip, reflecting 7 and its motor functions. You can also use a forceps. Be careful. Once you make the animal upset, it's difficult to continue your neurological exam. We can pinch the chin and look for the head being pulled up, assessing sensory 5 of the face. Cranial nerve 7 is also responsible for taste. Take a look at a piece of tongue between upper and lower jaw. Use a Q-tip with water as your baseline. Apply to the tongue, count the licks. Repeat with a bitter apple or spicy and see how many licks there are. Test both sides. Cranial nerve 5 and 6, trigeminal and abducent. Ophthalmic branch of 5 is responsible for sensory to the cornea. As you touch it, the abducens or cranial nerve 6 will allow to retraction of the globe. You are holding the fissures open. You should not have a blink, but if you weren't, there would be 7, which causes the blink. Here's another example. You may use a Q-tip or you may use your finger. Do not use a forceps or any sharp, hard object, which may be insulting to the cornea. Cranial nerve 8, vestibular cochlear positional strabismus. Placing the patient in various positions in your arms on the floor allows you to evaluate the globes for proper positioning. Both eyes should face in the same direction and should not rotate to any deviation. There should be no involuntary movement of the eyes either. Cranial nerve 9 and 10, glossopharyngeal and vagal, are assessed with a gag and a swallow. Open the patient's mouth and stick your finger down the throat. They cannot bite you with a finger down the throat while they are gagging. You're assessing a gag response. You may also stimulate the throat and assess a swallow. As most of neurology, these are very subjective, so practice on normal animals. Hypoglossal tongue symmetry. As you open the patient's mouth, check on both sides and check for the tongue muscles to be even. You may go ahead and stimulate the nose with water, your finger, and cause a licking. During that time, you can assess the tongue symmetry and the tongue function. It is not common to see a hypoglossal nerve injury, but here's a great example of a tongue deviating to one side more than the other. The third part is proprioception. We are looking at conscious proprioception first and assessing placing. Meet Rowan, another cattle dog. We are going to support the body to avoid any unconscious proprioception or vestibular input. Do not lift the patient, support only. Take away vestibular input. Take a look at the carpi in this dog and the others and pay attention the patient is not carried but simply supported. We are not touching the toes as they will be reluctant to participate. Simply curling at the carpus, the paw under, allowing the dog to sense the position change and place. Protect your back at all times. For a medium to large sized dog, you must position yourself in such a way that your back is not doing the work, allowing your ankles to support you. Place your hand behind the dog between the thighs, over the pelvis. Again, avoid touching the nails. Gently place. At times, the patient will want to pull away, leading to a withdrawal reflex and not a placing response. Here's an example of withdrawal. Be patient, take your time, and place. In a small dog, you can do so on a table, on a mat, or again, as I prefer to do so, stay on the floor. Support the patient, do not lift it, watch for the carpi, you will slide your hand gently down the leg, letting the dog know, or cat know, that you are going to be touching the feet. Again, avoid touching the digits or the nails, as they often become reluctant to participate. Curl the paw under, allowing the proprioception. Good support at the thorax, preventing any falling over, leaning over, loss of balance, and unconscious proprioception. This test is particularly important, period. It is very subjective and therefore must be done in repeated fashion with normal animals until you can assess your ability to perform this test appropriately. Have a good sense of what the patient's balance is, particularly important when you're assessing patients that have vestibular disease. Again, support the patient. You will see my hand being right under the belly in a small dog, but I have no pressure on the abdomen. As mentioned earlier, placing can be challenging. In a large dog, you will have to straddle yourself over the patient, bend your knees slightly, and be slightly more forward over the thorax. Place your hand comfortably either in front or behind the front legs. Slide down the leg, let the patient know you're coming. This is a great example of a patient not participating and not wanting to do the test. Patience is the key. Make sure you test all limbs. As we're moving to the pelvic end in this patient, realize that it's a larger dog and may easily pull you to the side. Again, support your elbow on your knee. Use your ankle to give the support. And this is what can happen when the patient is not cooperating. This patient, thank goodness, is mostly playful, but it could be more severe. So be careful and protect yourself. They do not like their feet touched. In this case, I'm using my hand in front of the limbs, initially, to reassure the patient. As you can tell, he is far more cooperative. I am now sliding my hand between the thighs. This is Tommy who will show you, after getting a disc herniation and surgery has a slight remnant of a left pelvic CP deficit. Proprioception is also assessed with hopping. This is used mostly when dogs are non-cooperative or in cats or smaller dogs. Simply lift one leg and push the patient towards the other leg. Lift one leg, push towards the other leg. Same thing in the backhand. Pivot the dog on the front or backhand that is not being tested. I am not lifting the patient. Wheelbarrowing is rarely done but can be of some value in patients, particularly in small dogs or in cats. Simply lifting one end, allow the patient to walk forward and backward on the opposite end. Hemi-walking and hemi-standing are also needed at times to assess slight weakness on one side versus the other. Simply lift the patient's right side and push towards the left, and then change. Repeat this a couple of times to ensure consistency. These tests are subjective. Do not lift the entire dog, simply lift the limbs. Practice, once again, will allow you to assess normal from abnormal more readily. Note that in all cases, we have good footing and a great yoga mat. Extensor postural thrust is essential in cats. Lift the cat, put the feet down on the ground, and watch the cat replace the feet under. Here's a wheelbarrowing. Most cats do not coordinate or cooperate for neurological exam. Be patient and be creative. Here's tactile placing. Same thing as visual, this time with blocking vision. Remember that cats and small dogs are used to being carried and may not do the placing. You must put them in an uncomfortable situation. Come up to the chair, and there's tactile placing. There are 3 appendicular reflexes in each limb. Front legs have biceps reflex C5 to C8 musculocutaneous nerve. Biceps is a flexor, therefore we will put a leg in slight extension by placing a finger behind the elbow and wrapping another finger on the insertion of the biceps, feeling the tendon gently. This is not a full extension. Gently tap your finger, one nice brisk tap, and look for the contraction of the biceps or a slight extension of the digits. There is a nice contraction of the biceps. The reflex can be done on the down leg as well. Extending the elbow, using your fingers to extend the antebrachium. Feel the insertion of the biceps tendon, tap gently, look for contraction or look for digit extension. Triceps is C7, T1, some of T2. The triceps an extensor, therefore we will create a flexion. Use the antebrachium, flex the elbow, move the elbow forward, abduct a little bit. You're going to have to play with this reflex a few times to find out in each patient what is the ultimate. You can see a nice contraction in Rowan. Remember, do not make it too tight so it won't respond. Withdrawal is a nociceptive reflex. You will pinch the toes and see the limbs come up. Pinching between the toes is also very helpful. Pelvic limbs, also 3 reflexes. Patellar reflex is the first one, L4 to L6, which is the femoral nerve. The femoral nerve creates an extension of the limb, therefore have the stifle in a semi-flexed position. Gently tap the tendon, patellar tendon on the bottom as well, should get a nice brisk extension of the limb. Gastrocnemius reflex, L7 to S1, sciatic nerve. This is a flexor of the stifle extensor of the hock, so you will create the opposite motion. You will slightly extend the stifle, you will flex the hock to create the maximum tension on the insertion of the gastrocnemius. You will look for contraction of either the gastroc or the semimembranosus tendinosus. This reflex can be done on the upper and lower leg. Some dogs are reluctant and will consider that more of a withdrawal. Again, find the right position. Practice makes perfect. You can do the down leg as well. The tail may be in your way. Hold it out. Get some help. Same thing here. The final reflex in the pelvic limbs is the withdrawal, sciatic nociception. You will go ahead and pinch the toes and look for a withdrawal. As you see in Rowan, there is no cross extensor, which is normal when the dog is laying down. Cutaneous trunci reflex is a lateral thoracic nerve, C8 to T1. You will pinch either side of the spine ahead of the ilium with your fingers or forceps. Both sides of the dog flank must contract. The lateral thoracic crosses over and therefore will communicate bilaterally to the lateral thoracic nerve, and then cutaneous trunci contraction. Perineal reflex, very important, S1 to S3, touching or pinching perineally, touching the vulvar area, bulbourethral area. Feel the tail tone. Again, this will take practice to know what normal is. In small dogs, you're going to have to modify at times. This is also applicable for cat. I can use my stethoscope head, I can use my pleximeter, I can use my heavier pen light. Any object that is fairly solid is enough. You will want to go ahead and position the patient on your lap in a comfortable fashion. The description that I use is positioning the patient like a baby, legs facing forward. Sometimes it is best for the owner to hold the patient in that position, and I can proceed to do the biceps reflex. This is a flexor. We'll extend the limb, testing musculocutaneous nerve. Gently tap your finger and look for contraction or extension of the toes. Switch around to the opposite leg, of course. Always test both sides. Most little dogs and cats are fairly comfortable in this position. None of these tests hurt. They're usually pretty okay with you doing them. Radial nerve, C8 to T1, an extensor, flex the limb. This is a little trickier to do in this position. Again, you need to practice and get comfortable with it. Gently tap and you will get a contraction of the triceps. Difficult to see in this black dog. Proceed with the other leg. From this position, it is easy to go ahead and do withdrawal. Pinch the limbs. You do not have to pinch hard, just enough to get a withdrawal. The patient by then is fairly relaxed, and you can proceed with the patellar You have now tested musculocutaneous, you've tested radial, you've tested withdrawal. You're going to go on to femoral nerve. Alternating helps you get the dog distracted and gives you a better reflex. Gastrocnemius will test the sciatic nerve, and this is easily performed in this position as well. Relax the dog. Here's a gastrocnemius tendon. You're flexing the hock, slightly extending the stifle, tapping at the insertion of the gastroc tendon, looking for a contraction of the semimembranosus tendinosus or the gastrocnemius muscle itself. Test both legs. In this position, you can also do withdrawals, and you can also do perineal reflex. S1 to S3 perineal nerve is being assessed. The same thing is being run through in a cat. Remember, cats do not have patience with you, so you need to be quick. You need to be accurate. Patella, sciatic, here's another trick, coffee table trick. This is not a reflex for the neurological exam, but just for fun, go ahead and scratch the ischium on one side and watch the opposite leg extend. No one knows why this happens, but it's a fun little trick to know in cats. This does not work in dogs, only in cats. Scratch the ischium and watch the opposite leg extend. Palpation, the last part of neurological exam, very important. Start with the part that is non-painful. In this case, we'll start with Rowan upper neck. Use a hand to pivot the upper neck around and the muzzle to shift the neck. Switch to the lower neck, support the upper neck so there's no mobility or twisting or bending of the upper neck, and rotate the neck around the pivoting hand. Same thing on the other side. Support the upper neck, rotate the lower neck around the hand, which acts as a fulcrum. Rotate the entire neck. Go down, upper neck, mid-neck, full neck. Go up, upper neck, mid-neck, full neck. Then we're going to proceed with palpation of the spine. You need to not squeeze, you need to not pinch, you need to simply put pressure and must be supported at all times. You watch my hands are supporting all the way down. In large dogs particularly, you will want to assess the LS, L67, L7S1 by pressing with your thumb down. You may also lift the tail. Another test is hemiinattention to assess the brainstem and the thalamus. Pinch one side, patient should turn to that side. Pinch other side, patient should turn to that side. This is normal. Assessing superficial pain is a pinch of the skin with forceps and look for cranial response. Tommy does not like it. Assessment of deep pain is using the back, the handle of the forceps, putting the toe and crushing the bone gently. The patient's respiration will go up or head turn. Thank you very much for participating in this exam. We hope you enjoyed it, and remember, practice makes perfect.